Welcome everybody to the case-based webinar on dermatopathology, organized by the Department of Pathology, Faculty of Medical Sciences, University of Sri Jawadanapura. And it is my great pleasure and privilege to introduce our resource person for today, Dr. Ruth Asher, a consultant dermatopathologist with a specialist focus on the microscopic diagnosis of skin diseases, who is currently working at the University Hospital Wales in Cardiff. She completed her histopathology training in Oxford, and in fact, it is from that time that the two of us have been friends. So it's a pleasure to have her on this webinar. She undertook a prestigious clinical fellowship in dermatopathology at St. John's Institute of Dermatology under the guidance of the famous Dr. Eduardo Calognier, where she refined her expertise in complex cutaneous pathology. Following that, she was appointed as a consultant dermatopathologist in Oxford before moving to Cardiff in 2020. In addition to her clinical work, she has served as an examiner for the RCPath Diploma in Dermatopathology and currently examines for the RCPath examination in histopathology. Her work combines diagnostic decision making and precision with a commitment to advancing patient care, education, and collaborative research in dermatopathology. I now invite Dr. Asher to commence the webinar.
Okay, thank you, Isha. First of all, I'd like to thank Professor Pramatilaka and for inviting me to give this talk today. I hope I don't bore you too much, but I thought what I'd do is I'd just cover a few diagnostic clues in dermatopathology, but I'm actually going to be focusing on, because of time, I'm going to be focusing on a few cutaneous tumours. I did have a plan to do some inflammatory as well, but as I prepared the presentation, given it's only an hour slot, it was getting a bit too big. So what I'm going to do is I'm just going to talk a little bit about melanocytic lesions and a couple of areas I think are particularly important, because I know you are a group of resident doctors or trainees, I'm not sure what term you use in Sri Lanka, at various stages in your training. So I'm trying to reach out to all of you across the board. And then obviously melanocytic lesions are always difficult, and as a dermatopathologist, even though I've been looking at them for years, I still find them difficult. And it's one of those lesions me and my colleagues tend to show around an awful lot. And then I just want to talk a little bit about basaloid tumours as well, because we do get an awful lot of basaloid tumours, and I just want to share with you a few little clues which would help to distinguish it from the more common basal cell carcinoma. Okay, so melanocytes, obviously very important cells which reside in the basal layer of the epidermis. So here we see a bit of normal skin, and we can quite easily pick out the melanocytes here. Often they will have small dark nuclei which are smaller than the surrounding keratinocytes, and then they tend to have this clear halo around them as well. They're not always that obvious on the H&E, but you know, when you can see the morphology, then great, and it's easy to assess whether there's a melanocytic lesion or not. Obviously, we've got a variety of immunohistochemical stains we can use to highlight the melanocytes, and this is melan A here, which you can see is just picking up the basal melanocytes, and it's demonstrating their dendritic processes as well. So this is, I would say, a normal complement of basal melanocytes. The number of melanocytes that we have in our basal layer varies from site to site across the body, but I would say on average there's probably one basal melanocyte for every 6 basal keratinocyte. And the whole purpose of this cell is to provide melanin pigment to offer protection against UV damage. And these dendritic processes will spread out, and they will feed around, on average, about 36 surrounding keratinocytes. And once they produce that pigment, then that melanin is pushed out into those surrounding keratinocytes to protect against UV damage. And it doesn't matter what type of skin you have, we all will have the same number of melanocytes, and it's down to the type of melanin pigment that's actually produced, which will cause the variation in skin colour. So obviously you will have all seen a nevus, and they are usually symmetrical lesions. I'm not going to labour on these, but I just want to point out a few little things that, you know, will help you when you're trying to distinguish it from a melanoma. So a nevus should always be symmetrical. So if we were to cut it right down the middle, one half should in effect kind of mirror the other half. Shouldn't have any odd fingers of tumour cells wandering off anywhere. And then it should be well circumscribed. And what I mean by this is, if you've got a junctional component, then it should end with a nest. You shouldn't have individual cells just tailoring off into the surrounding epidermis. If you see that, that's a bit of a worrying feature, and you've got to start thinking, well, am I dealing with a dysplastic nevus or maybe even a melanoma? And then, of course, maturation. If you've got a dermal component, then you should be seeing maturation. So maturation refers to the size of the nests and the melanocytes themselves. So in this picture here, we can just about see the overlying epidermis, but we can see the nests of melanocytes. They're quite large nests, and the melanocytes are quite large as well. I mean, they're not bigger than the overlying keratinocytes, but you can see with the nests a lot of intervening pink staining, which is actually the cytoplasm of these melanocytes. But however, when you get deeper down into the lesion, the nests become smaller, and this is what this image here is displaying. So they almost become individual cells, and on low power look almost like lymphocytes, and they look like they're intersecting the collagen bundles. So again, from larger nests to virtually individual cells in the deeper aspects of the lesion. That's what we would refer to as maturation. The other thing you need to look out for mitoses. You shouldn't see mitoses in nevi, and there are only very occasionally you can get the odd one, and that's acceptable. But the important thing about mitoses is that you shouldn't see atypical forms in a nevus, and if you are going to get a mitosis, you tend to see them more superficially. So in those nests that are just underlying the epidermis, if you see them deeper, you see atypical forms, again, you've got to start thinking, could this be a melanoma? Okay. So clinical impressions to start with. When I'm dealing with a melanocytic lesion, the process for me and making that diagnosis starts with the cut-up and what the lesion actually looks like. So here on the left-hand side, we've got a nevus. So it's usually small. Nevi, unless it's congenital nevus, they tend to be no bigger than 5 millimeters. Anything bigger than that starts to get a bit worrying. But it should have a nice, well-circumscribed border, and it should have nice, even pigmentation throughout. When we start to get lesions like this on the left-hand side, which is much bigger, having an irregular outline and variable pigmentation, the alarm bells are already ringing. Even if the clinician hasn't said query melanoma or rule out melanoma, I'm thinking, is this dysplastic nevus or is it melanoma? So when we get to the cut-up bench, obviously a good description is really important, especially in a department like ours where we use BMS cut-up. I'm not seeing these specimens anymore, so I'm relying on my BMS to describe this accurately so that my level of suspicion is raised by various things. So I'm sure you've probably heard about the ABCs. So A stands for asymmetry. So if we were to cut this in half, does one half mirror the other? And I would say definitely not in this case, because we've got this irregularity here, slightly smoother border here. The pigmentation is different here compared to here. And then the next thing is border. So is it a nice smooth border like we saw in that nevus on the previous slide, or is it irregular with all these indentations? And again, this is an irregular border. So again, this is another tick for a worrying lesion. And then C stands for colour. Is there variation in that colour? And we can see here we've got more than one shade of brown. We've got a very pale brown here, slightly darker, and then almost bluey black over here. So we've got at least 3 different shades of brown. Again, this is another worrying feature for potential melanoma. D stands for diameter. So by definition, dysplastic nevi, one of the defining features for dysplastic nevus is a lesion over 5 millimeters. So you can see here we've got a ruler at the bottom, and these are centimeters. So this is quite a large lesion. So again, this sets the alarm bells ringing. And I've just added the E for the ABCs, which is evolution. And obviously we can't comment on the evolution with a macroscopic specimen. This is what the clinicians will give us. This is a changing lesion. It was only very small, and it's grown recently, and it's darkened, and so on, and it started to bleed. So again, using the information that the clinicians have given us is another useful clue as to what this might be. And the reason I go on about this is because when you get your slides through, sometimes you can look at them and think, oh, well, this looks quite banal, really. I don't think this is anything to worry about. But then you read the macroscopic description. It's got asymmetry, it's an irregular border, it's variable pigmentation, it's a large diameter, and it's a changing lesion. I'm going to be really worried that there's going to be a melanoma there. And they can be very, very focal because they can arise within a pre-existing nevus. So that would encourage me to cut more levels on my specimen to make sure that I find that level of that area of malignancy or dysplasia. So cutting up melanocytic lesions, especially flat ones that are atypical, you need to embed the whole lesion. So you bread slice it from left to right or right to left, whichever way you tend to prefer to do this. And then the Royal College of Pathologists in London suggested it should be 1 slice per cassette. And the reason we put 1 slice is if there are issues with embedding and having to take deeper sections to try and get full face, if you've got more than 1 piece of tissue in a cassette and that's your entire lesion, you might end up totally trimming out the lesion completely in one section just to get that full face, and then you've lost an awful lot of prognostic information. So embed the entire lesion, single section per cassette, and levels. The only time I don't tend to do levels is if it's a really large lesion. So lentigo malignans can be quite large, and you could end up with 10 plus blocks. I don't want 3 levels or 4 levels on each of those. What I tend to do is I will look at the slides and then request levels from there, because you can just end up being overwhelmed with too much work. And again, if it's a really large lesion and it's a nodular lesion that's ulcerated, again, you're thinking, okay, this is going to be invasive. The part of the point of levels is to look for invasion and ulceration. But if it's quite obvious on the clinical, for example, in a lesion like this, where you've got a nodule, you know, if this is melanoma, then that nodule is going to be the invasion. So I'm not going to probably bother with levels on these larger lesions when I can see this nodule. And also, you know, some lesions can be of the size that you might need to embed the whole thing, 20 cassettes, you know, and for the sanity of your BMSs, you're not going to do that. So you're going to serially section the lesion and then lay it out and make a decision. Okay, where is the thickest part of the tumor? Okay, I'm going to embed that. Where do I think closest margins are? I'm going to embed those sections and deal with it like that. And it's just self-preservation, really. You need to make sure you've got accurate information, but you know, when you've got a nodule like that, you know it's going to be invasion anyway. Okay, so coming on to dysplastic nevus then. So as I said, with an ordinary common acquired nevus, the nests in these tend to just sit at the tip of the rete pegs like this. And you don't tend to get any melanocytes going up the edges of the rete pegs. When you've got a dysplastic nevus, I think, for me, one of the useful clues when I get a melanocytic lesion as to whether this is dysplastic or not is the elongation of the rete ridges. And that is one of the characteristic features of a dysplastic nevus. You're not getting a thin epidermis or very flat. You do tend to get these very elongated rete ridges. And then the nests don't just sit at the tip of the rete ridges. The melanocytes tend to spread up the side. You might get nests, as we see here, up the sides, and then we start to get individual cells depending on how dysplastic the lesion is. So it's a very disorganized pattern. And then the other thing is bridging of those nests. So we can see all the rete are joining up, and this is that bridging of those nests. You don't tend to get that in a nevus. So this is another important feature and clue to define a dysplastic nevus. Other things we can look for. So this is another dysplastic nevus. It's not as architecturally atypical as the other lesion, but what I wanted to demonstrate here was the lamellar fibroplasia. So you've got this fibrosis, it's concentric around the tips of the rete pegs. I mean, sometimes it's really prominent, sometimes it's a bit more subtle like this, but this is another useful clue for the diagnosis of a dysplastic nevus. Other things you need to look out for, they show variable atypia. If it's a melanoma, it's a very monotonous atypia. They're all large and atypical, whereas in a dysplastic nevus, you might get some smaller nuclei, and then other melanocytes are much larger. But the point is that they tend to be larger than the surrounding keratinocytes. If they're about the same size as keratinocytes, you're looking at sort of mild, about half a size bigger than the surrounding keratinocyte nuclei. You're looking at moderate. If they're up to about 2 times the size, you're dealing with severe. And it's the same with the architectural atypia. If the proliferation's starting to become more confluent and it's more disorganized, you're probably pushing more towards the severe sort of spectrum of a dysplastic nevus. Another thing as well, I mentioned about benign nevi, they are well circumscribed, so they end in a nest, whereas a dysplastic nevus is poorly circumscribed. So you have a nest, but then you might have individual cells running out, the lesion ending on individual or small clusters of melanocytes. The one thing you shouldn't get in a dysplastic nevus, though, is pagetoid spread. If you get pagetoid spread, you've got to start thinking about melanoma. Okay, so diagnostic clues. If you're worried about melanoma, things you've got to start looking for is confluence of that junctional proliferation. And what I mean by confluence is that the melanocytes are so numerous that they are completely displacing all the basal melanocytes. So instead of keratinocytes, so instead of seeing your normal basal layer of keratinocytes, you just see melanocytes. Pagetoid spread, really, really useful clue. What you have to be aware of with pagetoid spread is it's not confined purely to melanomas. You can see it in other circumstances as well. You can see it in if somebody's just had sunburn or recent sun damage to their skin. You can see a degree of upward migration of melanocytes, and you can see a degree of pagetoid spread or upward migration of melanocytes in acral nevi as well. So you just bear those things in mind. Now, as I said, in dysplastic nevus, you tend to get variable atypia. So you might get some large nuclei, some smaller. In a melanoma, the atypia tends to be more monotonous. So they're all large and atypical. You haven't got the smaller cells. The whole thing just looks atypical. Pushing borders, very, very useful as well. This indicates no maturation. So as I said, in a common acquired nevus, you start off with nests superficially underlying the epidermis, and then the deeper you go in the lesion, it tends to be individual cells. You don't get that. You get large nests all the way through to give you this pushing border appearance. And it's sort of counterintuitive to other malignancies that you experience in the body, because one of the features we always describe malignancy is an infiltrative border, but it's the opposite in melanoma. It's usually a pushing border. I mentioned mitoses. You shouldn't see mitoses in nevi. One is maybe acceptable, and the other situation you tend to see mitoses more frequently is a melanocytic lesion in a pregnant woman. The mitotic rate can increase. You tend to see a few more mitoses in nevi in children as well, because they'll be at that stage where they're actually growing, so it's no surprise. But if you see deep mitoses in atypical forms, then that's another alarm bell for melanoma. Ulceration, again, shouldn't see ulceration in dysplastic nevus unless it's been traumatized, they've been picking at it. Ulceration generally isn't a feature. Another thing to mention is consumption of the epidermis, which I'll show you a picture of in a minute, and irregular pigmentation. These are all clues to a potential melanoma. So melanomas have different histological growth patterns. So you will have heard of superficial spreading melanoma, lentigo maligna melanoma, nodular melanoma, and they're all defined by the growth pattern. And when we talk about growth pattern, we're talking about how the melanocytes are spreading throughout the epidermis. Now, if you've got a melanoma, the vast majority of the time you will have an overlying melanoma in situ component. So you'll have a junctional component to that melanoma. To have a purely dermal melanoma is rare. So this is where the growth pattern helps you to decide what type of melanoma it is and to confirm that diagnosis. So this is superficial spreading melanoma, and it's characterized by irregular nests of melanocytes, which are throughout the rete pegs, and then they start to migrate upwards as well. So this is our pagetoid spread, and that migration of melanocytes can be individual cells or nests. And true pagetoid spread is defined by melanocytes going all the way up to the granular layer. And as you can see here, this proliferation of melanocytes is confluent as well. We're not really seeing any intervening basal keratinocytes. This is, now, sometimes there's this misconception with superficial spreading melanoma. People think, oh, superficial spreading melanoma, it's an in situ tumor. Superficial spreading melanoma can be in situ and it can be invasive. It's in situ if you've got this particular pattern with the very prominent pagetoid spread, which we describe as buckshot, but no underlying dermal ness, or it's invasive superficial spreading melanoma if it's got that pattern, but then we've got the same atypical cells in the underlying dermis, and that distinguishes between your in situ and your invasive superficial spreading. Of course, there are other tumours that can give you this pagetoid spread. One of the commonest, obviously, extramammary Paget's disease, can be quite nested, but you will get this pagetoid spread. This has a very different clinical history. These tend to be erythematous lesions, most commonly in the perineal region, but can occur around the axillae and the breast. But if there is any concern, something's not adding up, the clinical sounds strange, you can always revert to immunohistochemistry. These should be CK7 positive, CEA, GCDFP15 positivity as well. They would all confirm. And of course, they would be negative for the melanocytic markers. And then another potential pitfall as well is pagetoid Bowen's disease. And sometimes the pagetoid pattern, you can have normal intervening keratinocytes with these atypical, what look like nests of cells, which are just keratinocytes, and they have this pagetoid pattern. You can see them going right up into the granular layer. So again, sometimes it can be so prominent, you will look at it and you think, oh, is that melanocytic or not? And again, there's no harm in just throwing a bit of immunohistochemistry to confirm that that is definitely keratinocytes, not melanocytes. Okay. Another pattern to just be aware of is lentigo maligna. So if it's in situ, so there's no underlying invasive component, it's just lentigo maligna. If there are atypical nests of melanocytes showing the same cytology as the overlying junctional component, then it's lentigo maligna melanoma, and you will follow the same data set criteria for Breslow thickness and so on through all these different types of melanoma. So lentigo maligna, this is a disease of chronically sun-damaged skin. So these patients tend to be older. They tend to be in their 70s, 80s, because they've got this accumulation of sun damage. And that's shown in the skin biopsy with quite marked solar elastosis, which we see here. But this differs from your superficial spreading melanoma in that the epidermis tends to be atrophic. You tend to have this confluent lentiginous proliferation of melanocytes along the basal cell layer. So no intervening keratinocytes. The basal layer has been completely replaced by atypical melanocytes, and then these have a tendency to go down the adnexal structures, as we see here as it extends down this hair follicle. Another type is nodular melanoma. Now, nodular melanoma, by definition, has to be invasive. It will have an overlying junctional component, which might look like lentigo maligna, might look like superficial spreading melanoma, but the difference is that junctional component should go no more than 2 Ricci pegs past the limits of the invasive component. So if I saw something that looked like superficial spreading melanoma over here, I'd say it's superficial spreading melanoma. But in this case, the junctional component is overlying the invasive component. It's not extending beyond it. It's not extending 2 Ricci pegs beyond it. So if that's the case, then you call it nodular melanoma. Now, another clue I mentioned was consumption of the epidermis. So we've got quite a large melanoma here, and it's quite obviously malignant, and I can find mitoses quite easily. Another one there. But you look at the epidermis here, it's looking very thin, and it's thinned out to no more than 2 or 3 cells thick. And this is incipient ulceration in effect, and this is a sign of a rapidly growing tumor. And if you left that any longer, then this would end up ulcerating. But that's a really useful clue as well. Ulceration. So we've got another melanoma here, we've got epidermis here, and then we've completely lost the epidermis here, and we've just got scale crust on the top here. So serous fluid, fibrin, with a mixture of neutrophils and some lymphocytes. Now, to say something's definitely ulcerated, you have to lose the keratin layer. If the keratin layer is gone, then you can say it's definitely ulcerated. The other thing is irregular pigmentation. Now, in an ordinary nevus, if this was an ordinary nevus, then your pigmentation tends to be in the melanocytes, in the junctional component, and maybe the very superficial nests. What you shouldn't see is deeper pigmentation. But in a melanoma, then you tend to see you've got an area of pigmentation here, deeper down in the lesion, you've got more pigmentation, and then another area of pigmentation there. So you've got this real irregular pigmentation throughout the lesion. Of course, cytological atypia, you're not getting that maturation. But when you look at the cells, they are clearly atypical, and you see cells like this, they've got large amounts of cytoplasm, but very irregular nuclei. And what's quite common in melanomas is they often have macronucleoli, as we see in this particular nucleus here. And then, of course, mitoses will often be easily identifiable. Not always, but usually you can count at least 5 mitoses in a melanoma, and we can see here we've got quite a large atypical form there. So that's another clue to the diagnosis. It's not as big a clue as the others. If you've got that degree of cytological atypia, then you're pretty home and dry with those mitoses. But some of the ones where the atypia isn't quite so marked, it can be very difficult, because you have to bear in mind that melanomas, although the vast majority arise de novo, so there's been no pre-existing lesion, they can arise in pre-existing nevi. So you might have an intradermal nevus component underlying your in situ component in the epidermis, and sometimes it can be difficult to be absolutely certain whether it's melanoma or not. We'll come on to that in a minute. But I talked about pushing borders as being a clue. So here we have our this is our deeper component of a nevus, where you've got individual cells which are infiltrating the collagen bundles, whereas we've got our nodular melanoma here, and you can see in the deeper aspects, it's large nets of melanocytes, completely different to this picture of a nevus. So another really useful clue. We can use immunohistochemistry to try and distinguish, to try and help us make a diagnosis of melanoma. So this is my usual panel. If I'm not entirely certain, I want to try and help confirm malignancy if the cytology is not playing ball. So I will use SOX10. SOX10 will be positive throughout for nevi and for melanomas and dysplastic nevus. What I like about SOX10 is it's a nuclear stain, so it highlights the nuclei and it really helps in assessing for maturation, because the nuclei are more obviously larger superficially compared to deeper if that maturation is present, and that's more obvious with a SOX10. So I find it quite useful for that. Then we might check the proliferation index using key 67. So nevus shouldn't be any higher than 5% positive cells. So in some melanomas it can light up. Sometimes it doesn't always play ball. HMB45 can be useful as well. So we should get zonation in a nevus. So we should have positivity of the junctional component with HMB45 and maybe the very superficial nest of a nevus. But in a melanoma, the whole thing tends to be positive, or you tend to get patchy positivity. Some of the nests deeper down are positive, some of the nests superficial are positive, and so on, and maybe in a checkerboard pattern. So that can be really useful. And then there are more recent immunohistochemical stains that have come on over the last 10 years. So P16, so this is part of the proliferation pathway, and it's what puts the brakes on and stops the melanocytes continuing to proliferate. So if P16 is maintained, then you should get diffuse positivity throughout the tumour with P16. And the important thing is you're looking, this is showing a lot of cytoplasmic staining, but you're looking for the nuclear staining and you're looking for the nuclei positivity throughout the lesion. If you start to lose that positivity of P16, that can be a very worrying feature for melanoma. And the same again with PRAME, which is a more recent immunohistochemical stain, and it's a nuclear stain, supposed to be positive in melanoma, negative in nevi. Now, the positivity in melanoma is between 85 to 92%, something like that. So that means not all melanomas are positive. So you can have some negative melanomas, and occasionally you can get positivity in nevi as well. So it's not an absolute game changer. And you've got to use these immunohistochemical stains in conjunction with the morphology to make sure you're not getting the diagnosis wrong. So don't hang your hat on a diagnosis. You might have something that you think looks quite benign, but looks benign, but then it's PRAME positive. Are you really going to call it a melanoma? You've really got to take the morphology into consideration. Okay, we have got molecular aids as well, which can help us in the diagnosis. So we can test for TERT promoters, and there are the melanoma FISH pros, of which there are 4, which give a pretty definitive answer to something being melanoma or not. Unfortunately, these, certainly not in the UK, these aren't freely available at the moment. So we're still having to rely very heavily on immunohistochemistry and morphology to try and define the diagnosis. Okay, moving then on to Spitz nevi. And the reason I'm going to talk briefly about Spitz nevi is because these are the tumours that tend to cause the most problems, particularly with, is it melanoma or is it just a Spitz nevus? Is it Spitz? Like melanoma, it can be a bit of a minefield, but you cast your mind back to those pictures I showed you of a nevus. Most Spitz nevi tend to look like this. They tend to be little pink papules, no bigger than 5 millimeters in diameter, maybe up to 10 millimeters sometimes. But then, of course, you do get the pigmented variety as well, particularly your spindle cell nevus of Reed. And usually the clinician will come back and say, oh, it's got a starburst pattern, which is what this picture here is demonstrating. So this is a dermatoscopic image, so very powerful magnifying glass jellies of lesion, and then the lens of the dermatoscope, if for those of you more junior haven't come across this, is applied to the surface of the lesion, and it gives you this starburst pattern, which are these little fingers of pigmentation coming out at the periphery of the lesion, and that's typical of pigmented Spitz or spindle cell nevus of Reed. So very different appearance to your ordinary nevus. But again, if you've got an atypical Spitz or a Spitz melanoma, then obviously things like asymmetry, border, and so on all play a part in formulating your diagnosis. Okay, so histology, Spitz nevus, they're very symmetrical lesions, so you should be able to draw a line down the middle, and one half should mirror the other. They're well circumscribed as well, so they should end in a nice nest. But for me, when I'm looking on low power for a Spitz nevus, one of the most useful clues is epidermal hyperplasia, which we can see here. In an ordinary nevus, the epidermis doesn't tend to be thickened, and in a melanoma, you tend to see thinning of the epidermis. So I think it's a really, really useful thing to bear in mind. If you see that hyperplasia, start to think, oh, could this be a Spitz? Okay, so the melanocytes, they're composed of, they tend to be larger than your melanocytes of a common acquired nevus. So we see them here. They tend to have larger vesicular nuclei, which tend to be comparable sizes to the surrounding keratinocytes or a little bit larger, but they have very pale chromatin and the nucleolus isn't particularly prominent. And then you tend to have abundant eosinophilic cytoplasm, and you get these very sharp nuclear borders because you tend to get this clefting between individual cells, which we're seeing here, and it really delineates the cytoplasmic border of these cells. And then these cells can either be spindle, as we see here, or they can be epithelioid as well. And then the nests, what they tend to do, they tend to rain down and run parallel to the rete pegs. Very, very characteristic. And it's a very sort of ordered pattern throughout the lesion. And then you can get these little clefts between the surrounding epidermis and the nests of melanocytes. And then another really useful clue to the diagnosis is the presence of cheminobodies. Originally, cheminobodies, they were thought to be keratin from the breakdown of melanocytes, but it's actually been found to represent basement membrane material. You can, sometimes they're not always evident. They've always said that you shouldn't, you find them less and less in the atypical Spitz melanomas. But that's not always the case, and sometimes you really have to hunt for them in an ordinary Spitz nevus. So I'm sorry, this is a massive table for you to take in, and I'm not going to go through everything on here, but you can actually, as this is being recorded, you'll be able to go through this in your leisure. But this actually comes from the WHO Blue Books. On the section on Spitz nevus, and it's just what I'm trying to show you here is now that we've found there are different kinase fusions occurring in Spitz nevi, and depending on the kind of kinase fusion that Spitz nevus has will determine the histological pattern. So probably the commonest and the one I've come across the most is the ALK fusion Spitz nevus, which tends to have a sort of a plexiform pattern with these elongated fascicles of spindle cells, almost starting to look a bit like a muscle tumor, but obviously you've got junctional mess. And then the next one I've come across is the NTRK fusions. So we found NTRK3 fusions tend to be characterized in the spindle cell nevus of Rees. Mutations in HRAS tends to define the desmoplastic Spitz nevi. So there are all these underlying mutations and kinase fusions. The reason, one, they have pattern, which, I'll let you sit down and read through that in your own time. So that can help distinguish the diagnosis. But knowing about these fusions is really useful because they're not just present in ordinary Spitz nevi, they're present in the atypical Spitz and Spitz melanoma. So if you find one of these fusions, and especially if you're thinking, oh, this is an atypical Spitz tumor or Spitz melanocytoma, as we now call them, you'll be moving away from calling outright melanoma. So this was a case I had in the last year, a spitzoid tumor, pretty well defined, well demarcated, with these what look like spindle cell nests superficially, and just coming in closer, you can see they're more sort of plump spindle cells. You can see that clefting between the individual cells, slightly larger vesicular nuclei, which is telling me, oh, this is a spitzoid lesion. And if I do show you the immunohistochemistry, this is ALK1, and there is immunohistochemistry for some of those kinase fusions. So ALK1 will be readily available because of its use in hematopathology. So these will stain cytoplasmically with ALK1. So that confirmed my diagnosis. Slightly atypical in its architectural pattern, which is quite typical for ALK kinase fusion Spitz-Nevi. But seeing that ALK positivity, it reassured me that this is a benign lesion and it's nothing to worry about. Other immunohistochemical stains that are readily available for these is Pantrac for determining the NTRK kinase fusion at Spitz-Nevi, and ROS1 as well is also readily available. Having said that, gold standard is actually doing next generation sequencing to confirm that. But as it stands at the moment in the UK, we don't have access to that. I'm hoping this will become available eventually, because again, immunohistochemistry, it's not one size fits all. It's not going to, you're going to get some false negatives. You may well get some false positives as well. So you really need to confirm the diagnosis with NGS, really. But as I say, it's not freely available. Okay, again, sorry, it's another really big table. And again, this is for you to digest in your own time. But it just, as I said, we've got a whole range of Spitz lesions. We've got Spitz-Nevi, Spitz melanocytoma, and Spitz melanoma. And we're just showing, what I'm illustrating here are the different distinguishing features. So Spitz-Nevi tends to be the younger age group. They tend to be a pinkish reddish papular nodule. Whereas Spitz melanocytoma, you tend to get a bit of colour variation, tend to be perhaps a little bit larger, slightly older age group sometimes, whereas Spitz melanoma, you're starting to see the asymmetry, the variable pigmentation, the evolution of the lesion, and tend to occur more commonly in the elder person, so anyone over 40, so that's me, ancient now then. And again, histopathology, you're looking at similar sort of things in a Spitz-Nevi. They are well circumscribed, so they're ending in nice nests. You have that nice epidermal hyperplasia. You do, something I didn't mention earlier, in Spitz-Nevi, you do get pagetoid spread in Spitz-Nevi, but it tends to be located within the centre of the lesion. It shouldn't spread out to the periphery, but if you're dealing with a Spitz melanocytoma, then you tend to get that pagetoid spread increasing and moving out towards the edges of the lesion. And then Spitz melanoma, it's very prominent pagetoid spread. And again, for these two, Spitz melanocytoma and melanoma, symmetry, asymmetry, very important features to look for, number of mitoses and so on. And again, Spitz melanocytoma, you start to get some increase in the size of the cells compared to those in a Spitz-Nevi, and then it's clearly high grade in a Spitz melanoma. But I think it's important for this group, because this group in particular, these are deemed low risk. They're intermediate tumours, but they are low risk. So they always tend to behave indolently. So, you're not going to be giving this melanoma sentence to a patient with Spitz melanocytoma. When I was a trainee, we didn't have the genetics. We didn't know about ROS1 and ALK1 and so on. So we had no way of distinguishing. We'd call these atypical Spitz tumours of uncertain malignant potential. And then these patients would often be overtreated to be on the cautious side. But now we have this information. We can throw some immunohistochemistry or do next generation sequencing to show it's a Spitz tumour, that it's got I don't know, a ROS1 mutation. We know, it doesn't meet all the right criteria of melanoma, so we're not going to overtreat those patients and label them with a diagnosis of melanoma. So you digest that in your own time, but you're just following the principles of atypia throughout. Okay, so that's enough about melanocytic tumours. I'm running out of time, so I'm going to have to whistle tour through basaloid tumours. So we all know what a basal cell carcinoma looks like. It's the commonest basaloid tumours. I probably diagnose 20 odd of these a day. And we know it's defined by, often the commonest one is the nodular basal cell carcinoma with large nodules of basaloid cells. You've got your peripheral palisading and you have your clefting artifact between the tumour and the surrounding tumour stroma. And when you look closely at them, they're not wildly atypical, but there is that little bit of pleomorphism, mitoses are evident, and there's apoptosis. It's an easy diagnosis to make, but there are lots of other basaloid tumours that can occur in the skin which can cause problems. So this is the first one I want to show you. All intents and purposes on low power, this looks like a basal cell carcinoma with a nodular pattern, but there is a big clue in this picture that's already making the alarm bells ring for me. I can see this clefting, but if you look closely, that clefting is between the tumour stroma and the surrounding dermis, and we see it here. We've got stroma. This clefting isn't going all the way up to the actual epithelial cells. For me, when I start to see that, I start to think trichoblastoma. And I can't emphasize it. It's one of the most useful clues. And every time I see it, I'm always starting to think, oh, is this a trichoblastoma? So how do you make that diagnosis of trichoblastoma? Trichoblastomas, these are benign hair follicle tumours. So we are looking for anything that indicates it's derived from the hair follicle. So here we've got keratinization here. So we've got swirls of epithelial cells with keratin in the middle. Now you can see that in BCCs, but but then you're going to have atypia of the surrounding cells. In a trichoblastoma, it's benign. The cells are very monotonous, and you can see here, they're all small, round, even cells. There's no mitoses, there's no apoptosis, so that's a reassuring feature. You might see primitive hair bulbs. If you're dealing with trichoblastoma, the primitive hair bulbs are harder to find compared to a trichoepithelioma, but this is probably one here. We've got condensation of the keratinocytes at one edge of this little nodule cells, which is typical what you tend to see in a very early hair bulb. And then if you're really lucky, then you'll start to see condensation of the mesenchymal cells underneath that as well, which is the papillary mesenchymal body. And then, as I've said, that's retraction artifact, and it's between the tumour stroma. So the tumour stroma tends to be a lot more cellular in a trichoblastoma compared to a basal cell carcinoma. You tend to get more cellular fibrotic stroma in an infiltrative basal cell carcinoma, but not in a nodular basal cell carcinoma. It tends to be more myxoid in appearance. So here we can see very cellular stroma with spindle mesenchymal cells, and our cleft is between that stroma and then the surrounding dermis. And as I say, biggest clue to potential trichoblastoma. Can do a bit of immunohistochemistry to help with the diagnosis. BOREP4, we all know basal cell carcinomas, negative for BOREP4. If we look at this tumour, you might get a little bit of patchy positivity, but if this was nodular BCC, this would be wall-to-wall positivity. CD10 highlights that stroma. You don't tend to get that in a basal cell carcinoma, but you do in a trichoblastoma. And then lastly, CK20, and CK20 highlights individual Merkel cells in the tumour itself. And you shouldn't see that in a basal cell carcinoma. Now, I say that, and that sounds wonderful. It can be really hard to find those Merkel cells sometimes in a trichoblastoma, and you really are relying on the morphology. So trichoblastoma, Whedon defines them as benign follicular neoplasms with germinative type differentiation. Kazakov, who's probably one of the leading authorities on adnexal tumours. These are biphasic epithelial and mesenchymal neoplasms, because you've got the mesenchyme from the surrounding hair follicle. And this includes trichoepithelioma, desmoplastic trichoepithelioma, and lymphadenoma as well. They all come under the sort of trichoblastoma umbrella. And they are a spectrum. So this is a trichofolliculoma here. They're all benign hair follicle tumours. They're just at varying degrees of differentiation. When I say a trichoblastoma is a poorly differentiated, and I'm not saying it's malignant, I'm just saying it looks least like a hair follicle. You're really searching for the clues. You're looking for that little keratocyst, you're looking for those primitive hair bulbs, whereas in a trichofolliculoma, you've got what looks like a dilated hair follicle with lots of little hair follicles coming off it. You move on to trichoepithelioma, there's lots of keratocysts, the primitive hair bulbs are quite easy to find, and then you move to the poorly differentiated spectrum of the trichoblastoma, where it looks more like a nodular basal cell carcinoma. But as again, I will reiterate, it's not malignant. CD10, I showed you, tends to be prominent in the stroma of a trichoblastoma, and this is just to highlight its hair follicle origin. If you do CD10 to a hair follicle, you see it highlights its surrounding stromal cells, its mesenchymal sheath. So it's mirroring what a hair follicle is trying to do. So trichoblastomas, briefly, solitary papules, nodules, typically on the head and neck. They don't tend to grow to any greats. 3 centimetres is the largest, but most of them tend to be no bigger than about a centimetre, and they usually tend to occur 5 to 6 decades, and quite common in nevus sebaceous. Okay, so another basiloid tumour we can see here. If we look closely, we can see it's a basiloid tumour, but it's got paler areas. This is connected to the overlying epidermis, as we see here. But as we zoom in, we can see quite clearly these cells have clear cell morphology, cytoplasm. Now, you can see clear cell change in basal cell carcinoma. That's important to note. This has also got peripheral palisading, but this has got what's called reverse polarity. So you look at these basal keratinocytes, usually in a basal cell carcinoma or in the basal layer of the epidermis, the nuclei tend to sit at the end of the cell that's closest to the basement membrane, whereas in this particular lesion, they tend to sit at the opposite pole of the cell. So you're leaving a clear cytoplasm between the nucleus and the basement membrane zone. So that's known as reverse polarity, which is typical for these lesions. And then we just look here, we've got slight basement membrane thickening. It can be variable for these tumours, can be quite prominent in some and more inconspicuous in others. Again, typical in these lesions. And then we've got a little area here where we've got a little bit of desmoplasia as well. So we've got more of that sort of hyaline pink basement membrane material with just little fingers of tumour cells infiltrating. But these tumour cells are very bland, and the rest of the tumour looks very bland as well, very monotonous population. So I'm not worried about malignancy in this case, but if you were to encounter this for the first time, you think, okay, that's infiltrative. Am I dealing with malignancy? So this is a tricholemoma, and that little bit I've just shown you here, that is the desmoplastic component. So they can be quite overtly desmoplastic tricholemomas at times, which can be worrying, especially if you get a small punch biopsy. You think, oh, am I dealing with an SCC or maybe a metatypical pattern in an infiltrative basal cell carcinoma? So you've got to bear this in mind. So tricholemomas typically occur in adults, head and neck tumours, can look warty, and originally were thought to possibly just be a feature of a wart and that these weren't neoplastic lesions. They've since found that there's a high frequency of HRAS activating mutations in these tumours, which confirms that they are that they're neoplastic. However, if these they commonly occur in multiply in patients with Cowden's syndrome, and a large proportion of those have actually been found to have, on PCR, to have HPV within them as well. And I've had viral warts that have had areas that looked pretty similar to trichomoniasis, but have only been very focal as well. But my point is that these are actually neoplastic lesions. If you're not sure about the diagnosis, then you can do CD34. And it's a very easy and freely available immunohistochemical stain, but CD34 will stain these tumours just like it would stain the outer root sheath, which is where trichomoniasis are thought to be derived from. So if we just look at a segment of the trichomoniasis here, the clear cell change, that corresponds to the clear cell change that you get in the outer root sheath in the stem of the hair follicle. And then I mentioned the slight basement membrane thickening. You tend to, it's not so prominent here, but if you've got a catagen hair follicle, you tend to get more prominent basement membrane thickening around a hair follicle, and that's what this basement membrane thickening in a trichomoniasis corresponds to. So if you're dealing with any kind of hair follicle tumour, the clues for the different hair follicle tumours: clear cells for outer root sheath differentiation. If they're matricial cells, very dark blue tumours with ghost cells, then obviously you're thinking of a matricial tumour like a pilomatrixoma or pilomatricial carcinoma. Infundibular keratinization, as we see here, or primitive hair bulbs, as we see here, then again another clue to hair follicle differentiation. And likewise, if you're thinking, oh, this could be a sweat gland tumour, then you're looking for sweat glands. Okay, another basaloid tumour with these cystic spaces. Yeah, it could be a BCC. It's quite dark for a BCC, if I say so myself, but you've got these paler areas here. If we zoom in, we start to see that these paler areas corresponds to nests of mature sebocytes. And the sebocytes are dotted throughout this lesion. So you've got these more basaloid tumour cells interspersed with these little clusters of sebocytes, not like you would see in an ordinary sebaceous gland, which we've got down here. You get germinative cells at the periphery, and then in the centre, the whole thing is mainly in a sebaceous gland dominated by the mature sebocytes. This has got a lot of what look like germinative cells with all those intervening scattered mature sebocytes. So if we look closer, we can see there's even holocrine secretion, which is and duct formation, which is further making me think this is going to be sebaceous rather than maybe a BCC with sebaceous differentiation, which can occur. And then we look closely at the cells. You can see very monotonous population, look very bland. You might get the odd mitosis in this particular tumour, but atypical forms aren't a feature, so they can be quite proliferative, but you shouldn't see atypical mitoses. So this is a sebaceoma, or sebaceous epithelioma is what we used to call them. These are benign tumours of the sebaceous gland, tend to occur in a slightly older age group, 5 to 6 decades. They're commonly seen on the head and neck. They're slow growing, and like any sebaceous tumours, they're often yellow-orange papules because of the presence of lipid in the sebaceous cells, and are quite commonly seen in nevus sebaceous as well. So for these, you differentiate because they can be quite mitotically active. Yeah, well, you might think sebaceous adenoma, and we'll come on to that in a second, but you might also be thinking, oh, is this BCC with sebaceous differentiation or sebaceous carcinoma? And one easy test that you can do is BER-EP4. BCC and sebaceous carcinoma are BER-EP4 positive, and sebaciomas are BER-EP4 negative. So that should help. You can see trichoblastomas with sebaceous differentiation as well. And poromas can also have sebaceous differentiation, but hopefully you should see other features of hair follicle differentiation for a trichoblastoma, or clear eccrine differentiation for a poroma. So this is a sebaceous adenoma, very different to a sebaceoma. What we have is a thickened layer of germinative cells around the periphery, but like a normal sebaceous gland, it tends to be the mature sebocytes that predominate. The only difference is that the germinative layer is thicker, whereas in your sebaceoma, you have more of the germinative cells with little clusters of sebaceous coelenterates scattered throughout those germinative cells. And then sebaceous carcinoma, again, because they're mitotically active, you might be worrying about malignancy. So things to look out for is asymmetry. They can have an infiltrative border, but they can also be pushing as well. But cytology is key here. This is our sebaceoma, very bland, small nuclei. This is our sebaceous carcinoma, larger nuclei with chromatin clumping and often irregular outlines should help you with the diagnosis. Sebaceous carcinomas as well also tend to be of an older age group. The other thing to bear in mind is Muir-Torre syndrome. So you can see sebaciomas in Muir-Torre syndrome, as well as sebaceous adenomas and extraocular sebaceous carcinoma. It's important to think about this because of its risk of internal malignancies as well. And it's all down to the mismatch repair genes. The ones that tend to be affected in Muir-Torre syndrome in the sebaceous tumours is MSH2 and MSH6, which go hand in hand. But clinical clues for Muir-Torre syndrome with sebaceous tumours is they've got multiple tumours, less than 50 years of age, sebaceous neoplasms, particularly below the neckline, and cystic sebaceous neoplasms. If your sebaceous neoplasm fits into any of these, then you can do immunohistochemistry to confirm to help confirm Muir-Torre syndrome. But it's important, and if you haven't got access to that, it's important that it's raised with your clinicians so that they can seek genetic counselling. So this is just immunohistochemistry for mismatch repair genes and a sebaceous tumour I've had previously. You can see MLH1 is positive, so that's retained. But MSH2 is completely negative. There's nuclear stain. There's nothing coming up. So this patient is likely to have Muir-Torre syndrome. Okay, another basaloid tumour. So we've got quite a large dermal tumour here. You can see it's composed of some large nests, and then we've got areas of smaller nests as well of basaloid cells. As we come into the areas of smaller nests, these are small nodules arranged in what I would call a jigsaw pattern. They look like they're fitting around each other. They look bland, and then the other striking thing is this very prominent eosinophilic basement membrane material around the nodules and within the nodules as well. But then in other areas, the nodules are much larger and composed of monotonous looking cells that we can see here. You know, they're not enlarged, they don't look atypical. But the important thing for this particular slide is this infiltration with lots of lymphocytes. You start to get your eye in, you can see they're infiltrated throughout this particular large nodule. And then when you zoom in, there are two cell populations. This is present also in the smaller nodules as well. You have these more darker basaloid cells, and then these paler, more eosinophilic cells. And then the other thing I'm highlighting here are the ductal structures. And because we've got these ductal structures, I'm now thinking, okay, this is a sweat gland. So this is actually a combination of a cylindroma and a spiroadenoma within one tumour. And there's often this histological overlap. And these tumours are probably more commonly seen in Bruchs-Spiegler syndrome, which is defined by a mutation in the SIL gene. And these patients typically have multiple spiroadenomas, cylindromas, these mixed tumours, and also trichoepitheliomas. They also both tend to occur in the head and neck, although you more frequently might see spiroadenomas on the trunk. Clues for separating between the two, because they can both have that basement membrane zone, but it tends to be more prominent in a cylindroma, and it tends to outline the entire small nodules, whereas it's not so prominent in a spiroadenoma. You tend to get the little higher lying globules in and amongst the cells. But infiltrating lymphocytes is a thing of spiroadenoma, not of cylindroma. And then most importantly, spiroadenomas are composed of large nodules. Cylindromas are small nodules. One last basaloid tumour. I'm aware I'm just running over, if that's okay, Isha. We've got a large tumour here. This is how it comes sometimes. It's guddled out. It's thought to be a cyst, and then it turns out to be some sort of basaloid tumour. This tumour is showing no connection to the overlying epidermis. It's very dark blue in appearance. We seem to have quite a few cystic spaces. We come in and we look at the cells, very, very monotonous, small cells. I would describe those small monotonous cells. They're kind of cuboidy. I would describe them as poroid cells. And they've got a degree of peripheral palisading as well. But I can't see any mitoses there. It looks very, very bland. And then if you look carefully, you get slightly more squamous areas around the areas where you can find sweat ducts. So again, we're looking at another sweat gland tumour. And then, as I mentioned earlier, you can have cystic spaces, and they're often dilated sweat ducts. And so if we were to look closer at this, you would see the lining would be sweat duct lining epithelium. So that tumour, this is a poroid hydradenomer. So it's got all the features of hydradenomer, but it's lacking that connection to the overlying epidermis, as you tend to see in a poroma. So this is a picture of a poroma here, and you can see it has extensive connection to the overlying epidermis. But everything else is exactly the same. It tends to be a large nodular lesion with poroid cells. But there are poroma, it is part of the poroma family, and there are different types of poroma. So we've got the classical poroma, which we see here, with that broad attachment to the overlying epidermis. They don't tend to go that deep. Then we've got hydroacanthoma simplex, where you tend to just get little nodules of poroid cells sitting within the epidermis. So it's kind of an in situ type, without trying to make it out to be malignant. It's not, it's benign. But they just, little nests of poroid cells sit within the epidermis. Then we've seen the poroid hydradenoma. So it's several large nodules of poroid cells, bland poroid cells within the underlying dermis with no connection to the epidermis. And then the other type is dermal duct tumor, which is multiple small nodules of poroid cells within the underlying dermis, which can show a little bit of connection to the overlying epidermis sometimes. So poromas, often solitary nodules, typical poromas, usually acral, palmoplantar, middle-aged patients. Poroid hydradenomas, you can see them on the trunk as well. Porocarcinomas is the one you've got to be careful of. These tend to be ulcerative, can be quite verrucous, and are more commonly found on the limbs and the trunk rather than those acral sites. Patients tend to be older, and there tends to be a longer standing history. It's important to be aware of porocarcinoma because they are quite aggressive. 20% can recur, so wide local excision is always important for excision. 20% can metastasize to the lymph nodes, and 12% will have distant metastases. So they are quite an aggressive tumour. So you need to be aware of porocarcinoma. But things that might help distinguish porocarcinoma, one of the features for diagnosing porocarcinoma is you will often see a residual benign poroid component to it. But you're then looking for things like irregularity of the tumour. So it's asymmetrical. You tend to have either pushing or infiltrative margins, but that the asymmetry is there. And then, of course, the cytological atypia, which we're highlighting here, with mitoses and atypical forms, very different to that normal poroid appearance that you see in a poroma. And then when you look at the ducts within the tumour, you will tend to see that those are also atypical as well. So sweat gland tumours, one way when you're eyeballing the tumour to sort of get a feel for what type of tumour you might be dealing with is to go on the size of the nodule. So large nodules are often spiradenomas, hydradenomas, and poroid hydradenomas. Small nodules tend to be your cylindromas and your dermal duct tumours. I've spelled sweat there incorrectly, forgive me for that. Poroid hydradenoma is different to a normal hydradenoma. So poroid Hydradenomas are thought to be ecrine hydradenomas because poromas are thought to be derived from the ecrine duct in the acrosyringium. So that's the portion of the ecrine duct as it travels through the epidermis. Whereas hydradenomas are thought to be apocrine, but in all these adnexal tumours, it's never that clear cut. You can see apocrine and ecrine differentiation in a lot of sweat gland tumours. So hydradenomas tend to be large, basiloid nodules, again, sometimes in the dermis. It's one of these tumours that always makes me stop and think, oh, what's this? But they can show connection to the overlying epidermis. And they tend to have a mixture of cells. So these are kind of slightly oncocytic looking cells with this more eosinophilic cytoplasm. I've got another slide showing the same, but they're bland nuclei. They all look pretty much the same. Mitoses aren't a feature. And then you can have areas with clear cell change. You might have goblet cells within that as well. And then more squamous-y looking cells as well, all typical for your apocrine hydradenoma. And then these are more of your other types of cell, more prominent eosinophilic cytoplasm. And then, of course, in the centre of hydradenomas, you can get these areas of sclerosis, and it can be quite marked, and entrapped within them can be little islands of lesional cells as well, which if you've only got a small punch biopsy, that can look quite worrying, but the cytology should hopefully put your mind to rest. But if you do get this, you're always going to have to recommend complete excision to be absolutely sure so you can see the outline of the tumour. And then the other feature, because they're sweat gland tumours, you should find sweat ducts within the lesion as well. So you can see it's very different to your poroid hydradenoma, which looks, for all intents and purposes, like a poroma, but it's not connected to the epidermis, it's large nodules. An apocrine hydradenoma has this variety of cells. It has the oncocytic cells, it has the squamoid cells, clear cells, goblet cells, but you still have the sweat ducts embedded within it. And sometimes they can be cystic as well. And again, these cystic spaces are lined by ductal epithelium. So hydradenomas have got a variety of different names that I picked off, I think it's WHO website, which can be very confusing. Call them nodular hydradenomas, clear cell hydradenomas, ecrine acrospiromas, clear cell myoepithelium. It's very confusing. It's hydradenoma is the term we use, or apocrine hydradenoma is the other common terminology for these. But these tend to occur head and neck, again, like most of these, and trunk, wide age range, can be quite large, up to 3 centimetres and I've already gone through all the features of a hydradenoma. I've run over, that's all I have to say, but that's just a whistle-stop tour through a few melanocytic lesions and clues for making the diagnosis, particularly distinguishing between spitzoid tumours and melanomas, and also a variety of basiloid tumours, and the various little clues that will help you make the diagnosis. So I hope this helps you in your day-to-day practice. And so thank you for listening. And if you've got any questions, then please feel free to ask me.
Yeah, hi, Ruth.
I'm so glad to hear your voice because it's so quiet, Isha.
Here I
I'm
am.
really worried.
Yes, there was a
question.
Yeah, there was a question earlier on in the chat box.
Okay.
Shani wants to know what markers can we use to differentiate dysplastic nevus from a melanoma? Is HMB45 helpful as we don't have PRAME?
I don't. The only reason I might do immunohistochemistry is when I'm looking for confluence of the proliferation and possibly to highlight pagetoid spread. So I might do a SOX10. I don't find HMB45 particularly useful. SOX10, as I say, it's a nuclear stain, so it tends to highlight the size of the nuclei, which can be quite useful for comparing it with adjacent keratinocytes. But, you know, it will also pick up any pagetoid spread or any confluence of the proliferation. I think with also with dysplastic nevus, another clue I'm looking out for morphologically, as I said, one of the defining features of dysplastic nevus is the elongation of the rete ridges. But if it's starting to evolve into melanoma, then you start to get flattening of that, and you tend to start to see in areas flattening of the epidermis, and that's where you tend to see the more marked confluence as well. But I don't think there is any other particular stain that might be helpful. Praying can help, but I wouldn't rely on it either, because sometimes dysplastic nevi can come up positive. So I think for this distinction, you're really relying on morphology and a bit of SOX10.
Okay, I think that answers her question. Are there any further questions? I'd like to remind participants who haven't filled the Google form to do so if you need the certificate. So any further questions?
I've stunned everyone to silence.
Anyway, so
That doesn't happen very often.
yes, it's been really useful, especially for people in centers who don't see so many, and then you get the sporadic one of especially
Yes.
those adnexal tumors, and you wonder whatever the heck it is. Okay,
Yeah.
so yeah,